Today we are talking with Dr. Robyn Bluhm, the author of Knowing and Acting in Medicine, an associate professor at Michigan State University at the Lyman Briggs College. Welcome to Readara.
Thank you very much. Thanks for your interest in the book.
A very interesting title, and of course you're touching on a lot of deep issues there. Tell us a little bit more about what the book is focused on.
So the book actually sort of began as a project in 2015. I had a conversation with Sarah Campbell, who is one of the editors at Rowman Littlefield International. She said that she was interested in developing a possible series of books in philosophy of medicine and asked whether I might be interested in putting together a proposal for an edited collection. I think that this is a really interesting time to be doing this in philosophy of medicine because as a field or a subfield of philosophy, it had a little bit of a heyday in the mid to late 1970s and then seemed to disappear. By contrast, bioethics, which is also very much a philosophical topic, has grown quite a bit since then. And it's really only in the last decade or so that philosophers have become interested in broader philosophical questions in medicine. There's a couple of exceptions to that. There's a big literature on the nature of health and the nature of disease, and there's always been a little bit of work on policy issues, partly related to bioethics. But questions about medical knowledge in particular, I think, have really not been until recently of great interest to philosophers. And given that the purpose of medicine and of health policy is to improve health, there's not much point in having knowledge and not thinking about also what to do on the basis of that knowledge. So that's how the basic idea for the book came into being.
What is the philosophy of medicine? And for those who don't understand what it means and what does it cover and how it has evolved in the last several decades?
I think really when we think about philosophy of medicine as a distinct field from bioethics, what people tend to think about are epistemological questions, so questions about knowledge in medicine, and metaphysical questions. So I mentioned earlier the nature of disease, the nature of health. Those are some of the main, or the two main areas that are distinguished from bioethics. But that said, I think that there's also a lot of interest in the relationship between ethical questions and these epistemological and medical questions. I think part of what sparked an interest in philosophy of medicine was evidence-based medicine as an approach to medicine. This goes back to the late 80s, early 1990s, and was an attempt by clinicians to ensure that medical practice was based on the best available evidence. But what they meant by the best available evidence was evidence from well-conducted randomized controlled trials. And I think one of the major topics in this sort of more recent renaissance in philosophy of medicine has picked up on that idea, because when you say evidence to a philosopher, our ears tend to prick up and we tend to start thinking, well, what do you mean by evidence? How do you know what's evidence? How do you know what's good evidence? So there's been a lot of interest in that as well.
As we know, the medical knowledge is, as you explained that in the book, there are three kinds of things: clinical research, clinical experience, and then pathophysiological understanding. But every clinician operate under a limited understanding of the medical knowledge because the patient-specific and the contextual features are also very important. Otherwise, that could be harmful in some ways.
Yes, absolutely. And I think this is, again, one of those areas where epistemological questions in medicine have to grapple with ethical issues as well. So there are actually several papers in the volume that look explicitly at the knowledge that patients have and also how that relates to medical decision-making, or knowledge that clinicians have of specific aspect of a particular patient's life and health and circumstances. So even though there's been an increased interest in clinical research and clinical trials, I don't think that anybody thinks that that's sufficient to enable good clinical decision-making.
How did we come to rely on evidence-based medicine versus expertise and knowledge and skills and all those other things that are relevant as well. And I think you have a good paper that has done a little bit of research on it. Can you explain to us a little bit more what is that they're trying to explain there?
Sure. So I think the first thing to sort of establish is that when the proponents of evidence-based medicine use that name for their approach to medicine, they really had a great rhetorical victory in a way. It's impossible to be against evidence or against practicing medicine on the basis of evidence. So the real question is not, well, what does evidence look like when, or what does medicine look like when it's not based on evidence, but more what kind of evidence is evidence-based medicine focused on? And again, especially in the earlier days of EBM, evidence-based medicine, the focus was on clinical trials in particular. I think one of the big motivations was that there were several studies that looked at medical decisions that tended to be made in different geographical areas, and that showed that, for example, in the case of breast cancer, whether a woman with breast cancer received a lumpectomy or a mastectomy had less to do with the evidence of effectiveness of those treatments and more to do with where she lived. So different areas just sort of had local practices, essentially, that had built up over time. And the people who started thinking about evidence-based medicine were very concerned that, they didn't think that it was a good idea for people to be treated just on the basis of local tradition or the preferences of an influential clinician in a particular area. So they were really concerned to give individual clinicians the power to engage with clinical trials themselves. So on the one hand, EBM was originally really meant to improve the skills of individual doctors in finding and assessing the available research literature. I'm not honestly sure the extent to which they sort of forgot about the importance of clinical decision-making, or whether they just sort of took for granted that that would have to happen after the research had been found and appraised. Early textbooks of evidence-based medicine would say things like, once you've found and you've assessed the quality of the literature, then you can apply it in practice, as if there wasn't anything really clinically or epistemologically robust about that. Later on, they switched to language that talked about integrating research results with knowledge of the patient's individual circumstances and values and the physician's own clinical experience. I think it's an open question how much that's really a change in evidence-based medicine and how much it's really a clarification of what the proponents of EBM had always intended to have happen. With that said, I think, over the past couple of decades, evidence-based medicine has just become remarkably successful. It's moved from internal medicine to all kinds of different areas of not just medicine, but nursing, physiotherapy. I believe there's even an evidence-based librarianship movement. So the phrase itself has kind of become incredibly successful, and the approach as well.
Stepping back a little bit, what are the large-scale issues with medical knowledge? And are there any broader things that, are we doing just in the U.S. or globally or worldwide, that there are certain things that are happening the way we are converting information into knowledge, or the way we are harvesting the knowledge, or the way we are propagating knowledge?
That's a really good question. I think that when we're thinking about different kinds of medical knowledge, we need to think about a few different things. So evidence-based medicine has been very good at focusing on clinical research. It's only very recently, and I think very reluctantly, that there's been an interest in the relationship between clinical research and physiological research, so research on biological mechanisms rather than on clinical outcomes. But I think that that's also incredibly important. There's also a need, I think, to do good social science research, and this is something that is being done to, for example, show how communication with patients can be enhanced and shared decision-making with patients can be enhanced by presenting information in different ways or using different techniques of eliciting patients' concerns and patients' values and beliefs. So I think that's another important area as well. Thinking globally, I think that this is something that, on the one hand, there's some reason to think that given that a medication in particular will have a specific physiological effect, that clinical research can sort of be exported from the geographical area that it was originally conducted in to other areas. But in fact, that's an oversimplification and possibly a dangerous one, because there are all kinds of other factors that can influence health outcomes and and patients' responses to particular medical intervention, including things like their other health problems, nutrition, all sorts of things that might vary in different contexts. And I think this is something that even people in wealthier countries need to keep in mind, because increasingly clinical research has been globalized and is being conducted in countries other than Western developed countries where traditionally it's been conducted. And the results of that research are now being used to treat a different population, but sort of in reverse. So knowledge is being brought back to these wealthier countries.
Absolutely. Now, going a little bit into the more nitty-gritty of the thing, how central is the reasoning process of clinicians? Obviously, there is certain logic that they follow, and over the years, they have built some biases. And so what are those biases, and what is their reasoning process that they employ before they arrive at any conclusion?
I think that clinical reasoning is absolutely central. And not being a clinician myself, I'm limited in how much I actually know about it from sort of an upfront perspective. The closest I've ever been is being a patient who's being reasoned about or reasoned with. That said, I think there are people in the area of philosophy of medicine who are doing some really important work on this. So in the Knowing and Acting volume, the chapters by Mark Tonelli and by Sophie van Balen and Mieke Boon are particularly interesting because they, in some ways, are very similar assessments of clinical reasoning, but also emphasize different sorts of things. She doesn't actually have a chapter in the book, but I would say that Mona Gupta is a psychiatrist who's been working on clinical reasoning specifically in psychiatry for the past few years and is trying to get a sense of how psychiatrists actually do reason and what counts as good reasoning as well within psychiatry. I think it's an open question how much that area of medicine differs from other areas. So I'm waiting to see what Mona comes up with.
Mm-hmm. In this, I think the chapter that is a paper where you have a paper from Anthony Fernandez, which focuses on the phenomenology and typification.
Phenomenological. Yes.
Tell us a little bit more about what is that paper consist. What does the paper consist of, and what kind of issues Anthony Fernandez is focused on?
So one of the things that I'm really excited about, actually, about this book is that there are several chapters that deal with psychiatry. For the most part, my impression has been that even though philosophy of medicine and philosophy of psychiatry are very active, those small areas of research in medicine, there isn't as much exchange of ideas and sort of mutual discussion between them as I would like. That said, Anthony's chapter in particular is really interesting to me because he has very solid training in phenomenology and has been bringing this to psychiatry. This, I think, is something that has been a tradition in philosophy of psychiatry, both in the sense that there have been psychiatrists who have been very interested in phenomenology. So Karl Jaspers was both a philosopher and a psychiatrist and sort of developed this phenomenological method within psychiatry. I think that one of the interesting things about this chapter in particular is that it not only uses phenomenological methods to look at questions about psychiatric reasoning and psychiatric diagnosis, but it does the reverse as well. It looks at specific use of phenomenology in psychiatry and sort of tries to use that to assess competing accounts of competing sort of theoretical positions in phenomenology.
What is phenomenology for people who don't know? Give us a little bit overview of it.
Sure. So the word actually is essentially the study of phenomena, the study of the way that things appear to us. And I'm not a phenomenologist, but my understanding is that this goes back at least as far as Immanuel Kant, who distinguished between noumena, the way the world really is, and phenomena, the way the world appears to us. And traditionally, philosophers have sort of aimed to get at the truth, aimed to get at reality. And phenomenology basically says that, essentially we can't really do that, but what we can do is learn about the world and about ourselves by developing very rigorous methods for studying the way that the world appears to us.
Mm-hmm. And while we're talking about this difficult to pronounce and esoteric words or terms, also maybe you can explain to people who don't know what is epistemology and what does it mean and how it's applied in this context.
Epistemology is one of the main sub-areas of philosophy. It's the theory of knowledge. Quite often people, when they think about epistemology, sort of think about the big questions. So this goes all the way back to Plato and his idea that knowledge is justified true belief. And in a sense, he's exactly right, but it turns out that there's a whole lot more to say about knowledge than that. Within medicine in particular, epistemology focuses on medical knowledge, which, as we've already discussed, has various aspects. So knowledge of medical research, knowledge of clinical decision-making, knowledge of patients and how to understand and communicate with patients. Essentially, I guess you can think about epistemology of medicine as just being a sub-area of epistemology proper. I was going to say that there are certain questions within epistemology as a whole that are certainly relevant in philosophy of medicine, but I think that there are certain things that at sort of a more fine-grained level are very specific to medical knowledge.
Mm-hmm, mm-hmm. And while we are on that topic, the next paper that you have, which is the next chapter also by Abraham Schwab, and there is certain humility in this knowledge that we have because it's not always reproducible. And what are the highlights of that chapter?
So I think that this chapter builds on some work that Abe Schwartz has been doing previously. And in that work, he was interested, I think, specifically in epistemology and humility in clinical reasoning. Here he's bringing that together with issues related to the replication crisis. So as you likely have heard, there's a lot of talk these days about scientific studies that originally look very promising and look like they give us very solid knowledge, but that don't end up being replicated by later investigators. So John Ioannidis, who has done a lot of work looking at this, he has a chapter, a paper, Why Most Published Research Findings Are False. And that goes back as far as 2005, and he essentially, even though he's not a philosopher, is doing epistemology in that paper. He's looking at different methodological reasons for and sort of broader reasons for why medical studies in particular are quite often not replicable. Psychology, I think, is another area in which the problems with replication have gotten a lot of interest lately. So to go back to the paper, what Professor Schwartz is doing is he's looking at the extent to which clinicians can rely on published findings and their reasoning about those published findings, given that all medical knowledge is uncertain, but that the replication crisis is making it more urgent that we think about how to handle that.
I think you bring it out in the early chapter of the book that no matter how good clinical reasoning may be, it is still fallible. And,
right.
And that's where the problem always arises. And I guess Professor Schwab, I guess, treats that in that chapter, or rather in that paper, and trying to explain that they're not always reproducible as they're published. They're very hard to reproduce sometimes.
Right.
Moving on to the next chapter, which is benefits and challenges of service user involvement in mental health research, reframing a model. Now that's something you talked about, the work that is done for the mental healthness, and that is a very interesting chapter because there are a lot of issues that generally people who are not in medicine could miss it.
Yes, I think that's absolutely right. And even though the chapter focuses on mental health research in particular, I think that this is a case in which a lot of the research that is being done, or work that's being done in philosophy of psychiatry in particular, has broader implications for other areas of medicine. So I think that in psychiatry, the reason that there's been more of a push to incorporate the perspectives of people who are using mental health services, it goes back to the anti-psychiatry movement in the 1960s. The worry that, in some of its more extreme versions, that psychiatric diagnosis was just an attempt to control people and to regulate people's behavior rather than a genuinely medical and helping profession. I don't think that necessarily that is the case, or that this is an opinion that was shared even then by many people, but I think it did draw attention to the fact that, in part because patients who are experiencing mental health issues are in some cases very vulnerable, clinicians had to be extremely careful not to sort of impose their values and their goals on patients. And now what this has sort of evolved into is recognition that in all areas of research, the ideal would be to consider service users as partners in the research. So they would be involved in deciding the research questions, in designing the study, in interpreting the results, and in helping to determine how to use the results in practice.
And in the next three chapters and the papers, that you have for the role of patient perspective, and also the science is clear and the value as evidence for mental illness and so on, there are a lot of very difficult and rather deeper issues that are dealt, like the values and evidence are interrelated in policy making and decisions, but sometimes they're kind of at odds with each other. And then medical knowledge is not something that only clinicians possess. They're value-based, and they have to be value-based and patient-centered. Unless you have all those holistic approaches, sometimes the cure could be worse than the disease that you're trying to cure. If you can give us a little bit of flavor of what is being talked about in those chapters.
Sure. So I guess there's a couple of themes that those chapters have in common. One is, as we've already discussed, the importance of understanding patient perspectives, or the perspectives of the public, and seeing what kinds of issues are relevant to people who don't have a medical background or a purely medical approach to the situation. The other thing that I think is important that comes out in several of the chapters is that medicine, but also science, are shot through with values. So values about how to do different types of investigation, what kinds of investigation to do. Essentially, I think we used to have the ideal that science would be value-free, that we would have sort of a pure investigation and then come up with knowledge that we could then use or put into practice depending on our values. But increasingly we've realized that the science itself is value-laden, that the kinds of questions that we ask are going to influence the methods that we use. So the methods that we choose are dependent on the values that we have. Thinking also about policy, we need to make value decisions about what kind of evidence and how much evidence is relevant to making different kinds of decisions. And I think one of the things that comes through really nicely in Susan Hawthorne's chapter is that the values that are the amount of evidence that we need to recognize that something is problematic and needs to be changed might be significantly less than we need to actually make a change to something else, because in order to change a policy or change a practice, we need evidence that what we're changing it to works as well.
A short but very profound question is that what are the bases of mental health policy? What are they?
That's a very good question, and I'm not sure what the answer is now. So in the chapter, this is actually an analysis of questions that were addressed in the early 1960s. And so at the time, a lot of care for patients with mental disorders was done in institutions, and these institutions were underfunded and overcrowded, and quite often there were not good treatments available for patients. And so the question was whether to shift from that model to something that was more community-based. Now, I think a lot of the policy questions and questions about clinical practice that are relevant to psychiatry are a lot more technical in a sense. So some of the things that have changed since then are the development of a variety of medications for different mental health diagnoses. There's a lot of debate about whether they're effective medications or the extent to which we should be using them. But essentially, unlike the early 1960s, we now take a very biological approach to psychiatry. We think of it as a branch of medicine. We think about mental disorders as being brain disorders. So the kinds of questions that we're asking are, I think, very much tied to that brain-based view of psychiatry. In particular, the BRAIN Initiative and the National Institutes of Mental Health's RDoC initiative, which is a way of using neuroscientific and psychological categories rather than diagnostic categories in research. They tend to be based on the assumption that the best way to make progress in psychiatry is to treat it as a clinical neuroscience discipline.
And then in the book we advance to the next couple of chapters, and there's a fascinating thing about the preventive medicine, and they may not be as completely benign as we think.
Yes. This is another case, I think, where the values that we have, on one hand, obviously, we want to prevent illness. We don't want people getting sick. But the chapter here sort of looks at what sorts of actions we might take for prevention and the extent to which we need to be able to justify those. So again, while the goal, I think, is relatively clear, and at least on the face of it, something that we can buy into, the question actually becomes what sorts of knowledge we need and what sorts of evidence we need to justify actually intervening. So one example would be screening for various diseases, so screening for prostate cancer, mammograms for breast cancer. These are public health campaigns that essentially are based on the idea that early detection leads to better outcomes and can prevent serious disease. But it turns out that things are a lot more complicated than that. People are worried now about overdiagnosis and about false positives. So it's not really clear that screening and prevention are always a good idea.
And that leads to the next question: is that what are the questions related to contemporary understanding of medical knowledge? Because there are also some important issues related to our understanding of the medical knowledge today. I think there's one chapter where there are always questions related to our understanding of the medical knowledge, and I think those questions, they were related to translational research and the gaps that we have?
Right. So I was talking earlier in the context of evidence-based medicine about the relationship between physiological research, so research on just how the body works and what goes wrong at a biological level when somebody has a disease, and then clinical research, which is aiming to, in a lot of cases, look at the effectiveness of treatments. And translational research, roughly speaking, is the idea that we start with a knowledge of physiology and then we move to clinical research, and there's sort of a linear progression to actually developing good interventions. And this chapter looks at, first of all, the various different ways that translational research has been understood. So moving from physiological research to clinical research, or moving from clinical research to clinical practice. And it also sort of argues that our idea that translational research is the right way to think about progress in medical science is very much a function of our broader approach to medicine. So one of the things that Professor Bluhm argues in this chapter is that, in the sort of 17th and 18th centuries, there was very little that doctors actually could do to help their patients. And so they focused on essentially making the patient feel better. And then as we learned more about physiology and we came to a different understanding of diseases, medicine started to focus more on the underlying physiology and sort of curing the disease rather than treating the patient. And I don't think that that is necessarily a bad thing. Obviously, we have all kinds of treatments that let people live longer and healthier lives now. But at the same time, there's certainly a shift, I guess, a shift in the way that we think about medicine. And in part, I think that, again, even given all of these successes, it's not necessarily the case that they've come without a cost.
And it also has how our concepts of disease and health shape the biomedicine and then create sometimes a gap as well.
Yes, I think that's absolutely right. So I had said earlier that questions about the nature of health and of disease are sort of central to philosophy of medicine and are one of the sort of longer standing sets of questions. And I think that, even though there are no chapters in this book that look specifically at that as a main focus, in the background there are, this is a consideration. I think actually the closest that we get to that is James Kruger's chapter on Ebola and ways of understanding the concept of cure and how that's contrasted with what they call supportive care.
Mm-hmm. And that was really good because in those two chapters, of the one on Ebola and the other on HIV/AIDS care, it's really, there's a rhetoric of medicine. There's more about, as you said, the treatment of patient rather than curing the disease, and then mm-hmm. just providing the support. Tell us a little bit more about what are those two papers focused on? One by Suze Burkhout and the other is by James mm-hmm. Kruger.
Sure. So I've already started mentioning a little bit James Kruger's chapter. He's very interested in looking at the distinction that gets made in the case of Ebola and other infectious diseases between providing supportive care and providing care that cures. So the basic idea is that a cure treats the underlying disease, and supportive care just sort of helps the patient to stay alive so that they can fight off the disease for themselves. And what Professor Kruger is arguing in this paper is that this distinction actually breaks down when we look at it. And given that when we saw the Ebola outbreak recently, we realized that people tend to be very afraid, and justifiably so, of this disease. When we talk about how there's no cure for the disorder, that kind of way of phrasing it might actually contribute to the fear, when in a very real sense there are things that can be done for these patients.
And, I think while talking about the HIV/AIDS, mm-hmm. there were a lot of different medicines that were applied, and there were all kinds of things that were tried. But it became a kind of a singular story, as the title suggests itself. Can you give mm-hmm. a bit more about what is covered in that chapter?
Right. So I think that even though the chapter on Ebola and this chapter are in some ways looking at very different health issues, Ebola is an infectious disease, it's acute, whereas increasingly HIV and AIDS have become chronic diseases that can be managed. They're really diseases that I think are very frightening to people and certainly have a lot, especially in the case of HIV/AIDS, a lot of stigma attached to them. And in this chapter, Dr. Burkhout is looking at the question of patient adherence to medication in particular, and the way that that is understood differently by different people within the healthcare system. So physicians might have a definition of adherence that focuses on whether the patient is actually taking their medication. Somebody who works at a community clinic might actually have a more nuanced view that takes into account the patient's circumstances and the broader context of the choices that she's making within her life. There's also, within research, specific ways of defining adherence that might be very different to the ones used in clinical practice. And one of the main issues in this chapter is to look at what happens when we focus just on a very narrow definition of adherence without really thinking about patients' context.
Mm-hmm. And in the last chapter, as you sum up in the book, it's got the title Action, Practice, and Reflections, and there's quite a bit of movement of simulation in the healthcare. Explain to us where it is going and how it is advancing the current, at the current point in philosophy of medicine.
Right. So this chapter, I think, is really, I'm really pleased to have it in the volume for a couple of reasons. First of all, it focuses very much on medical education, and it does so in the context of nursing specifically. So those are both really nice perspectives to have. That said, it also picks up on some of the questions in the earlier chapters about reasoning and how actually to make medical decisions and learn to make clinical decisions. So I gather that simulation is something that is used increasingly in healthcare training, in part because it allows learners to practice things that they may not actually get to do in a real clinical situation. And it also has a very practical approach to learning. So whereas a lot of the previous chapters thought about knowing in terms of pieces of knowledge, either from research or from conversation, this chapter very much focuses on actually doing and sort of more technical approaches to medicine or to care.
You've been listening to Dr. Robin Bluhm, the author of Knowing and Acting in Medicine. So much about the book. Tell us a little bit more about you. How did you get in philosophy? What attracted you? And then more so, how did you end up writing this book?
So I got into philosophy by accident. I originally wanted to be a translator. I enjoyed French in high school and decided that this would be a great job to have. And then I realized that enjoying French in high school was not at all the same thing as being bilingual. So I ended up deciding that my plans to get a translation degree were not going to work very well. So I ended up actually doing an undergraduate degree in neuroscience, which was surprising to me, but really fun. And when I was finishing that degree, we were talking about consciousness and the nature of the mind, and I wasn't very satisfied with what we were reading, so I thought, well, I should take some philosophy, and that's how that started. I was trying to decide, I guess, whether to go to graduate school in the sciences or in philosophy, and I sort of wavered on that for a while and then decided on philosophy, in part because I didn't enjoy being in a lab, and that was the main, I guess, the primary goal that I could see going to graduate school in science for. And how I got interested in philosophy of medicine instead of philosophy of mind was kind of a fluke. When I was starting my dissertation at the University of Western Ontario, I got a part-time job working for a dermatologist, writing review articles on fungal diseases of the skin. And this is where I first learned about evidence-based medicine. I found out that there was very little work done in philosophy looking at evidence-based medicine and decided that that was going to be my topic. So again, it was just sort of a strange confluence of factors, I suppose.
Currently, you're doing research and teaching, I guess, in the Michigan State University. And are there any specific issues that you focus on or during your research topics?
Yeah, so I actually am very interested still in philosophy of medicine and also in philosophical questions raised by neuroscience. So that first degree actually kind of did end up being useful. And I think what holds those together is, especially given the influence of neuroscience on psychiatry, is the philosophy of psychiatry. So those are, I think, the three main areas of my research. I also have an interest in sex difference research in neuroscience and some of the issues and questions that that raises. And I'm really lucky in that I actually get to teach in all of my research areas. So I teach a lot of bioethics. I've taught courses on not so much philosophy of medicine specifically, but certainly I've done a course in philosophy of psychiatry as well.
And you have a very interesting paper recently with 4 other researchers, I believe, is titled New Directions in Philosophy of Medicine.
Mm-hmm. Yes. So I guess this is the part where I get to sort of brag about philosophy of medicine as a field. I had said at the beginning of our conversation that it's a fairly recent or has become particularly active as a research area in philosophy in the past decade and a half or so. And it's gotten to the point where there's enough material out there and enough interesting research being done that there's reason to put together textbooks and reference works in philosophy of medicine. So there have actually been several of those recently. James Markham has published the Bloomsbury Companion to Philosophy of Medicine, and the Routledge Companion to Philosophy of Medicine was recently released. It's edited by Miriam Solomon, Jeremy Simon, and Harold Kincaid. And then the Springer has released a handbook of philosophy of medicine, which has been edited by Thomas Schramme and Stephen Edwards. So the New Directions in Philosophy of Medicine is in the first of those 3 volumes that I mentioned, the Bloomsbury Companion to Contemporary Philosophy of Medicine. And given how much interesting work is being done in the area, I didn't feel like I was competent to write the chapter on my own and do justice to all of these new directions. So I asked a few people who are doing some really interesting work. So the other authors are Jacob Stegenga, Sharife Tekin, Ashley Graham Kennedy, and Sana Yukola. We all have very different research programs, or where there's overlap, we take very different approaches. And so we decided to write the chapter essentially by starting with what we thought were the most interesting new directions and then putting it all together. And it turns out that there are, I guess, some themes and trends that are emerging, but I'm not sure that I'd want to use them to predict where philosophy of medicine is going next.
Mm-hmm, mm-hmm, mm-hmm. Thank you very much for your time and your comments, and it was enjoyable to listen to you and hear your views. And please do keep us in mind if you write another book.
Thank you very much. I really enjoyed getting to know your website, and I'm afraid that now that I know about it, my reading list is going to become even longer.
Well, there's ample time there, 24 hours every day.
There are, and I think I'm using 26 of them.
Thank you very much again. Thank you.
Thank you.